Hello everyone. Today we'll talk about a topic in gynecology. It's a short topic and it comes as a short note in your university exam sometimes. The topic is adenomyosis. So as the name suggests, adenomyosis. Adeno means gland, myo means muscle, and osis means condition. So basically it's a condition where the endometrium or the endometrial tissue, that is the stroma as well as the gland. The glands of the endometrium and the stroma of the endometrium is embedded into the myometrium. Okay, so the definition goes like this, that it's a condition which is characterized by endometrial tissue, that is the stroma plus the glands, into the myometrium, at least one low power field from the basal layer. So even if you don't remember the last line, that's fine. But you just have to remember, you just have to understand basically understanding concept is more important than cramming things. Because when you understand the concept, you remember it for a longer duration of time. Whereas cramming things cannot work in medicine because it's a huge subject. So the concept basically here is that you can extract from the name itself. So the endometrial glands and the endometrial stromal tissue is embedded into the myometrium. Now, how this endometrial tissue will go into the myometrium? So there are two possibilities that we can think of over here. The first possibility is that the endometrium, it develops from the Mullerian rests. There are Mullerian rests which give rise to the endometrial tissue. Basically you can, in easy words, if you try to understand it, it is like Mullerian rests are basically the embryonic endometrium. So the embryonic endometrium is your Mullerian rest. So there is metaplasia of these Mullerian rests into the myometrium. Now when there is metaplasia of this Mullerian rest into the myometrium, the Mullerian rest, they go into the myometrium, and there they produce the endometrial tissue. The second possibility that we can think of is that there is invagination of the basal endometrium into the myometrium. So the basal, we know that there are different layers of the endometrium itself. So the basal layer, there's a functional layer, there's a basal layer. So the basal layer goes into the myometrium. Fine. Now, just for the sake of knowledge, you can also know this thing that these tissues, adenomyotic tissues, they contain estrogen receptors, they contain progesterone receptors, they contain receptors for prolactin, growth hormone, and pituitary hormone receptors. Now, having this knowledge of these receptors in the adenomyotic tissue, we can use it for the purpose of treatment. We can give estrogen, anti-estrogenic drugs, okay, or we can block the estrogen receptors with the help of progesterone. Now, if you look at the pathology of adenomyosis, there are mainly two types. There's a diffuse type and then there's a localized type. Diffuse is which is present at different locations, and localized is that it is present at a specific location. So when there's diffuse adenomyosis, so there are diffuse foci of endometrial tissue in the myometrium, or there are different places in the myometrium where the endometrial tissue is embedded. So it will give rise to a uniformly enlarged uterus. The uterus will be uniformly enlarged, but it remains less than 14 weeks uterus. The size is less than 14 weeks. Okay. And if it's a localized tissue of endometrium which is embedded in the myometrium, then it is known as an adenomyoma. Okay, because it's like a myoma. Oma is a tumor, na? So it's like an adenomyoma, a tumor of adenoma kind of stuff. So two types. There's a diffuse type which gives rise to a diffusely enlarged uterus, and a localized type. Now see, whenever there is menstrual bleeding, so these spots of endometrial tissue will also bleed. Okay, and when these spots which are embedded in the myometrium, when they bleed, they give rise to hemorrhagic areas of adenomyosis. So obviously these spots of endometrium which are embedded in the myometrium, they will also bleed, and they will give rise to hemorrhagic foci. Okay, so this is what you need to know. So they are diffuse. So there are diffuse and localized varieties. In diffuse, the uterus is diffusely enlarged, and then it gives rise to hemorrhagic areas of adenomyosis. And if it's a localized type, it is known as a adenomyoma. That's all. If on microscopy we see there are islands of endometrial glands, okay, in the myometrium. Okay. So on microscopic examination, there are islands of endometrial glands in the myometrium. Risk factors are multiparity, okay, and any previous uterine surgery or trauma, okay. So that could be like in the case of dilatation and curettage. If we do dilatation and curettage, and or there is an induced abortion that we do. So the way to remember this is that, see, whenever there is any trauma to the endometrium, then what is happening is that you are poking the endometrium, and when you are poking it, so think of it like it gets activated and it starts proliferating, and then there is so much of endometrium that it cannot just stay in its place, and it migrates into the myometrium. So this is just a way to remember it, that multiparity, okay. So multiparity is a risk factor, and uterine surgery or uterine trauma is a risk factor, mainly after dilatation and curettage and induced abortion. And multiparity could be because it could be a risk factor, maybe because repeated pregnancies cause repeated trauma to the endometrium. This could be a reason. I'm not sure because it's not mentioned anywhere, but just to remember it, you can think of it like repeated pregnancies cause repeated trauma to the endometrium, which results in adenomyosis. The clinical features would be dysmenorrhea and heavy menstrual bleeding. Dysmenorrhea would be of congestive variety. Now imagine in the myometrium there are endometrial tissues are embedded. Fine. And during menses, during the menstrual flow, the myometrium is contracting, and this myometrium which is contracting, it has in it the endometrial tissues. So it will give rise to a congestive type of pain. Okay, so it will be a congestive dysmenorrhea. It will be a painful menstruation, and there will be heavy menstrual bleeding because there is increased surface area of endometrium, or there is increased amount of endometrium. Okay, in the uterus there is increased amount of endometrium, and wherever this endometrium is present, normally it's outside the myometrium, but now it is the spots of endometrium are inside the myometrium also. So there is increased amount of endometrium. So there will be more bleeding. So there will be heavy menstrual bleeding, and there will be dysmenorrhea of congestive variety. When you have to make the diagnosis is mainly based on, it's made by ultrasonography, and ultrasonography is done to distinguish it from leiomyoma of the uterus or other conditions which affect the uterus, or other conditions which cause heavy menstrual bleeding and dysmenorrhea. So ultrasonography is done to make the diagnosis. On ultrasonography, what we see is, suppose we are doing a transvaginal ultrasonography or transvaginal, and on this ultrasonography you will see that there is asymmetric enlargement of the asymmetric thickening of the uterine walls. Okay, the uterus will be uniformly enlarged, but the walls will be asymmetrically enlarged, asymmetrically thickened. So there will be asymmetrically thickened uterine walls, and there will be myometrial cysts. So there are cysts inside the myometrium. Cysts are basically cavities. So there will be cysts inside the myometrium, and there will be a loss of the normal endomyometrial border. So the normal endomyometrial border will be lost, obviously, because now the endometrium is migrating into the myometrium, so there will be no proper demarcation. Now moving on to management. Management is of two types. There is a medical management and there is a surgical management. In medical management, we have NSAIDs, okay, NSAIDs are basically given to treat the dysmenorrhea and to relieve the heavy menstrual bleeding. But the effect of this NSAIDs is temporary. So it's given for a short duration of time, maybe because you are waiting for a surgery. So then you can give the patient NSAIDs. The second drug is that we can use as an anti-estrogenic drug, because we know that this adenomyomatous tissue has estrogen receptors which causes it to grow. So if we give anti-estrogenic drugs, that can reduce these lesions in size. So the anti-estrogenic drug that we use here is danazol. Okay, then we also know that these lesions, they have GnRH receptors also. Okay, gonadotropin releasing hormone receptors also. So now normally the gonadotropin which is released in a pulsatile fashion, okay, which creates a positive impact. Now if we give GnRH analogs, or we give GnRH in a continuous fashion by using a drug, by giving a drug, we are giving a GnRH in a continuous fashion, so that will ultimately act as an antagonist. Instead of acting as an agonist, it will act as an antagonist. Okay, so these GnRH analogs can be used if we are waiting for a conservative surgery to do. So before the conservative surgery, we can use GnRH analogs to reduce these adenomyoma tissues in size. Okay, so the adenomyoma can be reduced in size so that it is easier to remove on a conservative surgery. So GnRH analogs can be used. Then surgical management is also there, and in surgical management we have a definitive surgery and we have conservative surgery. Definitive surgery is basically for older women or the perimenopausal women, and the conservative surgeries are basically for the young women who want to preserve their uterus, who want to conceive in future. Okay, so in definitive surgery we have hysterectomy, and in conservative surgery we have resection of the adenomyoma. Now there is adenomyoma in the myometrium, so we can either resect that adenomyoma or we can remove that part of the myometrium, so that is known as the myometrial reduction. Okay, so we are reducing the myometrium, or we can just only remove that adenomyomatous tissue, so that is adenomyoma resection, or then we can use a hysteroscope and we can do the resection of that area of that lesion using a hysteroscope. So there can be hysteroscopic resection. Okay, so the conservative surgeries are resection of adenomyoma, or myometrial reduction, or hysteroscopic endometrial resection. Now there are some newer interventional techniques like endometrial ablation. Obviously endometrial ablation, as you know, it will damage that endometrium so that it will not cause symptoms. Okay, and there can be uterine artery embolization, which is also a newer technique. So if we embolize the uterine artery, so the blood supply to this adenomyoma will be decreased and they will regress in size. And there is another entity also, that is magnetic resonance guided focused ultrasound surgery. It's MRGFUS, that is magnetic resonance guided focused ultrasound surgery. This was all about adenomyosis. Thank you.